Mastering the interpretation of a 12-lead ECG in the context of congenital heart disease requires moving beyond standard adult ischemia-centric thinking. In congenital heart disease, the ECG is a map of hemodynamic stress reflecting chronic pressure or volume overloads that have physically reshaped the myocardium. Before looking at hypertrophy, you must establish the heart's position and internal arrangement. Dextrocardia, look for global inversion in lead 1, that is negative P, QRS and T waves, and a lack of R wave progression in precordial leads. The frontal plane axis, extreme right axis deviation plus 180 degrees to minus 90 degrees is a hallmark of many cyanotic congenital lesions. Conversely, a superior left axis deviation, negative QRS in 2-3 AVF in a cyanotic infant strongly suggests an atrioventricular septal defect or tricuspid atresia. In congenital heart disease, we look for pure forms of hypertrophy that are rarely seen in acquired adult disease. Right ventricular hypertrophy is the most common finding in congenital heart disease like tetralogy of Fallot and pulmonary stenosis. Pressure overload characterized by tall R wave in V1 more than 7 mm and a deep S in V6. You may see a pure R wave in V1 with no S wave, which is highly specific for severe right ventricular hypertrophy. In volume overload, look for RSR prime pattern in V1, that is the incomplete RBBB pattern. This is classic for an atrial septal defect. Left ventricular hypertrophy is seen in ventricular septal defects and patent ductus arteriosus with large shunts, the Cack-Vactal phenomenon. This is a classic congenital heart disease finding. Look for large biphasic QRS complexes in the mid-precordial leads V2 to V4. This represents biventricular hypertrophy caused by a large left to right shunt. Moving on to the atria, they often provide the first hint of the underlying defect. P pulmonale, tall peaked P waves more than 2.5 mm in lead 2, indicates right atrial enlargement and is common in Epstein's anomaly or severe pulmonary hypertension. P mitral, notched P waves in lead 2 or a deep terminal negative deflection in V1 indicating left atrial enlargement in large VST and mitral stenosis, which could be congenital. Certain congenital heart defects have distinct ECG patterns that are almost diagnostic. Second MAST, right axis deviation plus incomplete RBBB, that is RSR prime in V1. Primum AST or atrioventricular septal defects, superior left axis deviation plus RSR prime in V1. Tricuspid atresia, the classic pattern is left axis deviation, right atrial enlargement and left ventricular hypertrophy occurring in a cyanotic neonate. Tetralogy of Fallot, right axis deviation and severe right ventricular hypertrophy, that is tall R in V1 plus sudden transition to S wave in V2. Epstein's anomaly, Himalayan P waves, massive right atrial enlargement and bizarre RBBB pattern, not the typical pattern, and short PR interval indicating WPW syndrome associated axillary pathway. As the congenital heart disease patient ages, the 12-lead focus shifts from hypertrophy to arrhythmia and conduction delays. Post-surgical scars from atriotomies like mustard or Svenning procedures create re-entry circuits leading to intra-atrial reentrant tachycardia. In repaired tetralogy of Fallot, a QRS duration more than 180 milliseconds is a significant predictor of ventricular tachycardia and sudden cardiac death.